Right. It's a great pleasure to introduce Nicki, who I met accidentally last November in Cape Town. She has dual expertise in public health as well as genomics. And she's also the deputy director of her Bioinformatics Institute in Cape Town. I know she has several lectures, and please do interact. She's got lots of wisdom for you guys to pick and share. Thank you, Nicki.
Thanks very much. Hi, everyone. So I'm starting today with two quite practical kind of refresher lectures. So I apologize for some of you, you may already know all this stuff, but I thought it's worth going over study design, because if you don't understand how your data have been generated experimentally, you can make terrible errors in your analysis. So for anyone who's done epidemiology, this would be very dull. But I still think it helps us, we can make sure that we're all using a common language to describe how we're talking about research that's been done. And I've already heard some references. People have been talking about whether data are longitudinal, whether they're cross-sectional. And I know we're going to be looking at survival analysis later on in the course, which is longitudinal. So I think it's really worth just going over study design and how studies are put together and what we can and can't derive from the different study designs. So also for people who aren't statisticians, understanding these things can help you have a better interaction, a more fruitful interaction with your statistician. Oops, sorry. And yeah, you can just learn how to describe your data sets in a way that makes sense. So often now in epidemiological journals, you'll see, or clinical journals, describing your study design is part of the forms you have to fill in when you submit your research papers. So it's worth being clear on these. So what is epidemiology? It's a study of the patterns, causes, and effects of health and disease conditions in defined populations. So I think all of us working with health data are working at some level with epidemiology. Maybe we're looking at genomics of populations and genomics of patients, but we're still looking at large data sets of health data arising from people, from healthcare clients, from individuals, from patients. This has also been mentioned previously, but it's not a bad idea to go over it. We talk about different terminologies, and I always find it interesting moving between the worlds of bioinformatics, machine learning, epidemiology, clinical research, how we have different languages to describe the same things. So an outcome is the main health outcome for which we're trying to understand causes and patterns. So for health research, this is often a particular disease. And an exposure is a factor that may have an effect on or association with the outcome. But these are sometimes called risk factors, causes, determinants. The language is ever evolving. We also talked about this previously, but just to note that causality is when an exposure actually causes the outcome. The outcome is a direct result of the exposure, but it's very difficult to prove. So in most cases, when we're looking at studies, we are looking for an association, a correlation between the exposure and the outcome. And it's very difficult to prove that it's causal unless you take something into the lab. So a correlation would be that when there's a greater exposure, there's more disease. But there could be an external factor that's driving both the exposure and the outcome independently. So I'm just going to go through the 5 main types of study design. Sometimes people refer to this as a hierarchy from the least informative through to the most informative. But I prefer to think about them as just being different ways to answer different questions. And sometimes we're constrained by resources or time. So often you have to choose a study design that works in your context and is capable of answering the questions that you want to ask. So I'll go through these 5 case series: cross-sectional studies, case control studies, cohort studies, and then the randomized control trial. I'll talk about the characteristics of the study design, the benefits and the limitations of each of the study designs, and then what we can calculate from each study design. And then I know it's also been touched on, but just to come back to bias and confounding, because these are also very important in understanding what you can and can't take from your study designs. So the first one I want to mention is a case series we'll talk about. So this is a group of clinical cases, normally assembled by a clinician who maybe has a specialization around that particular condition. A case study or case report is for one patient. So this may be an unusual patient and you can read about that particular presentation. But when you have a case series, this might be a new syndrome that hasn't been defined before, or a particular illness that is very rare. And you may have a register of patients who have a disease, a particular disease, a group of patients with the same illness. There's no comparison set, there's no control set who doesn't have this condition. It's literally a group of patients who have a particular condition or phenotype. So it is useful. I know as computational people, we can't imagine why this might be useful, but clinically it means that we can explore the nature of the disease and the environmental history and the medical history of the patients and get some insights into natural history of this particular disease. So it definitely provides us with a better understanding of the disease and its processes. And of course, if you are working with a case control study, you may want to go and look at certain case series so that you can understand the case set better and know exactly what is the phenotype of the condition that you're exploring. So obviously no inferences can be made about the underlying causes of the disease. The study's observational. You just are looking at what exists, what is, and it's descriptive. So there are no analyses to understand relationships between exposures and outcomes. It's kind of a documentation, a detailed documentation. So moving on to a cross-sectional study, this is now a larger study where data are collected at a single time point from a population, like a snapshot at one moment in time. So even though the measures may be taken on different days, there's only one measure per participant in this study design. And you have a defined population. This doesn't mean necessarily a geographical population. It might be a population of people who are within a certain facility on a certain day, or population of people who have a certain condition and are visiting a particular clinic. But each participant is only seen once. And at that time, that person will have a whole lot of measures taken. The prevalence, oh, sorry, I think did this jump forward? No. We can look at the prevalence of the outcomes of interest in this population at that point in time, and the prevalence of any exposures of interest as well. So it's an observational study design, in that at that moment in time, we're also measuring what is the situation on the ground right now at this point in time. So the prevalence is how much of the outcome or exposure is present in the population under the study at that one point in time. And we can look at the association between the outcome and particular exposures of interest at that one point in time. So if people have kidney disease as the outcome, do they also have hypertension as the risk factor? And are these two correlated in the population of interest or not? So it's an analytic study. I say to my undergrads about analytic studies, you can do some sums. There's some maths involved. You can look at associations between the outcome of interest and the exposures of interest. And the study, the calculations are quite straightforward. You have people who have the outcome or the disease status, and people who don't, and people who have the exposures of interest and people who don't. So just like we saw the confusion matrix earlier, in epidemiology, the 2x2 tables are like our staple of calculating these different measures. And you can use these to calculate the prevalence. So I've done all the sums here. The slides will be available to you. I'm not going to go through the maths, but essentially how many people in this population have the outcome, how many people have the exposure, and then you can stratify according to who has the disease and the exposure, who has the disease without the exposure, and vice versa. and you can work out the prevalence of the outcome in people who had the exposure, the prevalence of the outcome in people who didn't have the exposure, and then you can calculate a ratio. So the prevalence ratio tells you whether having the exposure of interest is associated with having the disease. And you can get actually a kind of a ratio that suggests how much more prone people are with the exposure to simultaneously have the outcome in this, at that moment of time in this particular study. So when you interpret the ratio, the sort of stock interpretation is that people who have the exposure are, and then depending on your prevalence ratio, maybe it's 2, are 2 times as likely as people who have not had the exposure to have the disease. It allows you to do some comparisons. And of course, you would have a p-value, statistical measure, et cetera, that come with the statistical test. Yeah. It's very good for describing disease prevalence in a population, and it's quite a quick and inexpensive approach because there's a one-off, you see everyone once, you take all the measures you need to take, and you can also look at many exposures and diseases in one study. So you can measure multiple disease outcomes, you can measure multiple risk factors or exposures, and you can do multiple association studies from the same data set. So it's quite a practical way to get a lot of data at one point in time. But you also have certain types of bias. So you're more likely to sample prevalent cases for a disease with a long duration. So if there's a one-day virus sweeping through your population, you're not going to get a great sense of who had the virus, because if you don't catch people on that one day, you're going to miss that they had the illness. So if you have a short prevalence of outcome or exposure that you're interested in, the chances of getting an accurate representation of who's had the outcome or the exposure is much smaller. So if you're looking for people in South Africa, we do a lot of work around people living with HIV. It's much easier to document in a cross-sectional study who might be living with HIV because it is a lifelong infection, whereas something like flu is very transient. And you also can't assess whether the disease or the exposure came first. So temporality can't be decided from these data. And in fact, the kidney disease hypertension example is a bit of a cheeky one because clinicians will argue which is the outcome, which is the cause. You don't know which was the driver of which because you're only measuring them both at the same time. Yeah. And also a cross-sectional study won't include anyone who's deceased because of the outcome of interest. So a classic example is the Ebola virus. So if you went and measured at one moment in time, everyone who's exposed to or has Ebola virus, you're going to be missing a very important part of your patient population. And that is those who didn't survive the infection. You can only measure the prevalent cases. You obviously can't have any assessment of the risk of developing the disease over time. So if the disease, if the exposure happens very early and it leads to a very long-term distant outcome, it's very difficult to pick that up from a cross-sectional study. So I used the example of asbestosis and asbestos exposure because the time lag between the exposure and the outcome is really sometimes decades. A case control study compares a series of cases of with a particular outcome with a series of comparable controls without the outcome. So there's a strong effort to make your control group as similar as possible to the case group in every aspect, except that they don't have the disease of interest or the outcome of interest, so that you can make a fair comparison between the two groups and try and understand some of the drivers of the diseases. So the case control study also investigates the exposures or characteristics of interest between these two groups. So case reference study, case comparison study, case compare study, case control study. Essentially, you have two groups that you've selected according to whether they have the outcome of interest and whether they don't, whether they can be in the case group or the control group. And as I said, the control should be absolutely as close to the case population as possible, except for this, difference of the one having the outcome and the other not having the outcome, so that we can make the comparison with as little kind of bias or skew in the data as possible. The number of controls can vary, the case control ratio. So traditionally, you'll see case control ratios as around 1:1. Very seldom have I ever seen fewer controls than cases. But actually, you can increase your statistical significance by increasing your number of controls in your data set. So I can actually, the optimal number I was told is about 4 controls per case. But I've never really seen studies that ever reach that level. So I think that might be just wishful thinking in many cases. Yeah. So resources and power calculations determine actual numbers that you end up with. And I would also add, if anyone here actually understands power calculations, can we make them a little slot somewhere on the agenda so they can explain them to us? Because I always feel like they're a bit of mystical magic. So I'd say always refer to a statistician for your power calculations when you're designing your studies. And sometimes they're matched analyses where you actually, for every single control, for every single case you have in your data set, you find someone and you match them demographically as a control. Those require quite a different statistical approach, those studies. So again, speak to your statistician. Don't try this at home. Yeah, it's not straightforward. So case control study, we've got the characteristics. So I hope you're seeing a pattern here that you draw up these 2x2 tables and you can do different calculations, but the calculations are very dependent on your study design. So you end up with the exposed, the unexposed, and then the cases and the controls. So D plus, D minus are disease, not disease. E plus, E minus are exposed, not exposed. And you can put this into, oh yeah, what can you calculate? You can't calculate prevalence because this is not a population study. You've actually specifically selected people who have the condition. So this is not representative of the population at all, and you shouldn't be trying to talk about prevalence or population statistics in any way. Yeah, you haven't sampled a population randomly, you've specifically selected to enrich for people with your outcome of interest. You can look at what exposures are related to the disease. This makes it an observational study. You're observing what is. And the distribution of the exposure in the cases controls can be compared. So it's an analytic study. You can do sums. You can do math. What you calculate from a case control study is an odds ratio. So an odds ratio compares for people with the condition, the likelihood of having had the exposure, to people without the condition, the likelihood of having had the exposure. I hope I got that the right way around, but I've got the formal interpretation coming up. So using your 2x2 table, you can once again calculate the odds of the exposure amongst the cases, the odds of the exposure amongst the controls, and you can build a ratio from this sum. So your odds ratio will give you an indication of the likelihood of people who have the disease having had the exposure of interest. So if I read through that, imagine you have an odds ratio of 2 or 3. An odds ratio of 3 would be quite high. People who have the outcome are 3 times as likely as people who do not have the outcome to have had the exposure. So the interpretations I've given, they're kind of the formal interpretations. Sometimes if you plug in the values, it feels a bit weird or a bit clunky, and you can always then modify it so it sounds like better English or it reads more comfortably. But they give you the accurate way of reporting those particular effect sizes, those ratios. And they will always come, when you calculate them with R or whatever program you're using, they will always come with a significance value that tells you whether that is a statistically significant finding or not. So make sure you always report your odds ratio. So trends change. Sometimes people prefer to put the p-value But the trend currently is to go with a confidence interval for your measurement. They both reflect the same thing. Confidence intervals are just more in at the moment, from what I understand. Anyone's welcome to comment on that further. So case control studies have some benefits. They're relatively quick and not too expensive. You're not going out there and looking for thousands and thousands of participants to get a big enough cross-sectional study. And they're very good for rare outcomes. So if you're looking for a rare outcome in a cross-sectional study design, you'd have to get a massive population group to get enough of your rare outcome represented. So for rare outcomes, a case control study makes a lot more sense to be able to get enough cases. And you can study multiple exposures, but you can't study multiple outcomes. So you often see in the big cohort studies, they talk about nested case controls. We'll talk about cohort studies, but sometimes in a big data set, you can actually subselect cases and controls and do a subset case control study, which can be quite useful. Yeah. So it can be difficult to get controls. Actually, this is often one of the more difficult parts of case control study, and it can be difficult to select controls that are truly close enough to the cases, that the people are similar enough that you're not getting a biased control set. You also have some selection bias. So sometimes the way clinicians select the cases, they might select people for a study if the people are more ill or they present in a certain way or it's a particular interest of theirs. You have recall bias because you have to speak to the people who have the illness and who don't have the illness and ask them about exposures that they've had. So a classic example for those, if somebody has had an adverse pregnancy outcome, they're more likely to remember that they had flu in the first trimester than someone who had an uneventful pregnancy outcome, who will sort of forget that they actually had flu in their first trimester because they don't have a reason to try and remember what might have gone wrong. So recall bias is quite a big problem, that people have different motivations for remembering different exposures. There's no temporality in terms of what came first, because you weren't around to assess the development of exposures followed by the cases. And you can't estimate the prevalence because it's not a population study, and you can't estimate the risk over time of developing the outcome or disease. So moving to a cohort study, a cohort is a group of people who share a common characteristic within a defined period, or share common characteristics within a defined period. So they must come from the same population group. Again, a population doesn't always mean a geographical population. It could be a population of people who had experienced a certain event, or a population of people who are all subject to exposure to a certain disease, or here an example, a birth cohort is a group born in a certain time period. So a population cohort, when people talk about a population cohort, that is a population cohort that represents a sector of the general population and is kind of inclusive. It's not a subset of people, but the population can be defined as different groups of people. The important thing is that when you start out the study, none of the people in the cohort would have the outcome of interest or outcomes of interest that you're planning to look at. So at the beginning, the participants don't have the outcome. Some will experience the exposure over time, or the exposures you're interested to, and others may not or should not. I mean, if everybody has the same exposures, you're going to struggle to find anything meaningful in your analyses. But some will have the exposures naturally over time and others won't. And then you follow up the cohort over time to see who will develop the outcome. So it's also an observational study in that you're seeing what happens naturally, what is you're observing and recording, but you're following up over time. And I think as it said here, it's also called a follow-up study, a longitudinal study, an incident study. There are lots of different names for following up over time, this a population that you're observing. Now, just to say again, at the beginning, all the participants don't have the outcome of interest when the study kind of kicks off, the starting point. And not everyone has to start the study at the same calendar date. They just have to start when they enter the study, that is their start point. For a birth cohort, obviously it's the moment of birth that they're enrolled in the study. But I may join a cohort 2 years later than you, and my starting date would be 2 years later than yours, and then I would be followed up from that point on. But at that point of entering the cohort, I wouldn't have the outcome of interest that the cohort is looking at. And there can be many different outcomes. It doesn't have to be only one. So it can be, a cohort study can be a prospective cohort. That means that I recruit the participants today, they come on board, and then I follow them up until 2030 or whatever the agreement is. So we're going to follow those individuals over time, see how they do, have follow-up visits, and follow them forward into the future. But a retrospective cohort study is where you can investigate a cohort from some years back for a certain amount of time. So in a retrospective cohort, the data may already be there. It's just a case of building the cohort design and going back in the data, deciding the entry point as recorded in the data for each individual, and then using the data to follow their progress over time. So you could have a retrospective cohort where the end date was 2021 and the data started in 2010, for example. And if the data are available, you can do very useful cohort analyses using those retrospective data. Yeah. So here was an example of a retrospective cohort. Army personnel from 1990 to 2000. In 1991, 100 were transferred to a different base. Compared to 100 who remained at the original base, what was the risk of malaria infection for the two groups? So the data all already existed, but it's a study done over time. When did people get malaria or not in the time? And the exposure, 100 had a different exposure. In this case, exposure was geographical location. So I realized that when my slides get bored, then they move on automatically. They're like shuffling me along. So again, you can build the same 2x2 tables, bearing in mind that there's a time element. We have a study population with no outcome. They're each exposed or not to certain exposures. And then you have the groups at different time or who had the exposure and the disease, etc. Yeah, so it's a fairly repeating pattern how we pull these data together. So what can you calculate from your cohort study? You can't calculate the prevalence of the outcome in the general population because everyone you brought into the study at time point 0 had no outcome. In order to be in the cohort, if you have a TB cohort where you want to look at the incidence of TB, when people join the study, they have to have no TB. Otherwise, you can't see when the TB happens, right? So you can't then use that cohort to estimate the prevalence of TB in the general population because you've subselected a group without TB. You can compare the incidence of the occurrence of the outcome in time for the exposed group and the unexposed group. So it's an analytic study. You can do sums. You can look at a risk, you can calculate a risk ratio. So you look at the incidence in the people who had the disease and the outcome and the exposure, and the incidence in the people who had the outcome without the exposure. And you can you can calculate this risk ratio. In fact, the units cancel out, so risk ratio is also without units. But just to understand, the incidence comes with units. The incidence unit is cases per person, years. So how many years have people been in the study and how many cases have there been per person per year? So you have to factor in that there's a time element because this is measured over time. So as soon as you see any analysis where there's something about person years, you know that this was a longitudinal study and probably a cohort study. And you need to keep that in mind when you're looking at things like incidence, is what is the time factor that's being used. But again, when you calculate the actual rate ratio, your incidence units cancel out and you end up with a ratio. And it can be interpreted with the standard interpretation. If your rate ratio is 3, people with the exposure are 3 times as likely as people without the exposure to develop the outcome over a 3-year period, or however long you've chosen for your study period. So when you interpret, you have to be very clear about the time factor, the time element. Limitations from a cohort for a cohort study, it's very time consuming. Sometimes cohorts take many years, especially if you're looking at some kind of outcome that takes a very long time to develop. If there's a long lag between exposures and outcomes, it can be really a costly business to keep following people up. It's not good for rare conditions because you need a really, really large sample size to be able to follow up and detect who's going to have the rare conditions over time. And we have a huge issue of loss to follow up. So this is when people stop coming back for follow-ups, when they can't be contacted. And it can be very difficult for bias because loss to follow-up might be related to someone's physical phenotype. So maybe if they have very bad symptoms or if they have excessive exposures, that can affect whether they want to stay in the study or not. So often loss to follow-up is not random, and that can cause you a lot of issues in how you calculate and interpret your data. And then selection bias, exposures are not always random. So for example, if the example I used here, if women have a very high familial risk of breast cancer, they're unlikely to be prescribed HRT by their hormone replacement therapy by their doctors. So there's a natural selection against that exposure for people with that risk. So if your outcome of interest is breast cancer and your exposure of interest is HRT, you've already got a skewed data set if you're following up through a cohort. So you have to be very, very careful of this kind of natural bias that creeps in. The benefits of the cohort study is that you can start looking for temporality, what came first. You can at least say with confidence, these people had the exposure before they had the outcome of interest. So this is where we're starting to explore causality. We're not necessarily proving it, but we certainly can at least say which came first. And that's a big step forward. You can calculate the risks and rates of incidence directly, and you can study multiple outcomes. If you're following up with a cohort, you don't have to limit yourself to only one outcome. And you can look at also at rare exposures in these kinds of cohorts, because you've got a large group and you can see the individuals. You can make sure you select individuals for your cohort who have the rare exposures of interest. So you can enrich your group to make sure you have representation of certain exposures, as long as they don't have your outcome of interest already. But they're very expensive cohorts to run, and it's hard work following up, and it's hard work managing loss to follow up. So the final study is the randomized controlled trial. So in essence, the sort of statistical design of this study is very similar to a cohort. But in a randomized control trial, the investigator intervenes. So this is not observational, it's actually an experimental study design. And the investigator has an active effort to influence the outcome through controlled exposures. So at the beginning of your study, everyone has neither the outcome nor the exposure. And then the exposure will be applied, maybe a medication, a vaccination, behavior change. So just to flag that exposures and risk factors statistically are not always negative things. They're often interventions to try and have a positive outcome. And then you attempt to define the relationship between the exposure and that you have applied and the outcome. So it's an analytic study. You're doing sums, but you're also controlling what happens to the participants, what exposure they receive. So it's prospective only. You must recruit participants and apply the intervention. And it's something that's very important is the random assignment of participants to receiving the exposure or not receiving the exposure. And this is to prevent bias. So you can imagine that if your recruiting physician feels very strongly that certain people who are their patients might benefit more from a new drug that's on trial, they may be more inclined to put people with certain disease phenotypes into the trial, to receive the active drug, the active medication. So random assignment is really essential so that it's completely random who's assigned to the control group, who's assigned to the treatment group, to try and avoid that kind of bias. And then double blinding where possible, it's not always possible, but where possible, neither the investigator nor the participant actually know whether they're receiving the real treatment or intervention or whether they are receiving a placebo. And this helps to remove bias, placebo effect, these kind of things. So the calculations are like those for the cohort study. All the participants start out without the outcome, then some receive the exposure, and then some will experience the outcome during the time period of the study. So you can calculate the incidence, you can't calculate the prevalence, and you can measure the number of new cases that occur with time in people with the exposure, people without the exposure. So yeah, it's analytic and you get a rate ratio. So people with the intervention are 3 times as likely as people without the intervention to have remission from the disease over a 3-year period. Let's hope for that medication. The benefits, these provide the strongest information about whether interventions are effective because you're actually applying the intervention and then measuring the effects in a controlled way. So if you do randomization correctly, you can prevent confounding and selection bias to some extent. And you can also confirm the temporality. You know that the exposure preceded the outcome. So the information you get from randomized controlled trials is fairly powerful as a motivator towards saying that you think there's true causality. But randomized controlled trials are complex and very time consuming, and there are a lot of ethical considerations. So there are some interventions or exposures that you simply cannot ethically apply to a population. And you also can't withhold a treatment that you're fairly confident is beneficial and has been shown to be beneficial and safe. So there are a lot of ethical considerations about what is allowed in randomized controlled trials, obviously for all the right reasons. There's also, there are always issues of bias and who enrolls in the study, who's likely to leave the study. If the intervention, for example, causes people to feel ill, they may be more likely to fall out of the study and not come back. So there's always this risk of loss to follow up and biased loss to follow up that can make calculations more tricky. So this is just a summary of study design. If you're never sure, it's just like a flow chart, a decision tree. If there's a comparison, if there's no comparison, it's most likely a case series. If there is, then it's an analytic study. Is the exposure under the investigator's control? If not, then it's observational. If it is, it's experimental, which is the RCT. If it's an observational study where the exposure is not under the investigator's control, if you're sampling by the outcome, it's most likely a case control study. If you're sampling by the exposure, it can be a cohort study. And if there's neither a specific outcome or exposure sampling strategy, you're looking at a cross-sectional study. So obviously this may not cover every eventuality, but it's just a helpful summary if you're getting stuck where you're at. So I just want to quickly go over bias and confounding, but we already had quite a bit of discussion around this, so I won't take too long. What is bias? So I'll also use the, some of the harsher definitions that my lecturers use. So validity is the truth of the finding. The internal validity is what has been found for the sample is true for the study population that the sample came from. External validity, what has been found for the sample, is true for other populations as well as the study population. But bias may compromise the validity of the study. So it makes it difficult to take the results of the study and say that they're applicable in the wider population. So measurement biases, are there different types of bias? There are names that are given to different types of bias. There's measurement bias, which can arise out of misclassifications or error in information obtained in the study, particularly if it affects one comparison group rather than another. So examples of this, if you have recall bias, I mentioned that already, where people remember differently depending on whether they have an outcome or not, and you actually capture the exposures incorrectly based on recall bias. Ascertainment bias is where you fail to represent all types of people in the population under study. So you may only have certain people who get diagnosed for certain reasons in your study, and you've missed out a whole lot of people who should have also been included as being diagnosed in the study. You can have calibration errors, faulty measuring instruments, and laboratory error that can all lead to systematic error in your study data. Selection bias, you may have selected participants who are different in some systematic way from the true underlying population of interest. So some examples, I mean, they have all these names, but they all speak to the same principles. Volunteer bias, so for example, health-conscious people are more likely to join a health-based study or a study about healthy living. Non-response bias, so for example, those who indulge in risky sexual behavior might be less likely to provide information about that because they feel it's stigmatized or so. Healthy worker bias, if you go to the office to take a survey of people who have flu, you're unlikely to find a lot of people with flu currently in the office. So that's healthy worker bias. You see the people who are well. And then loss to follow-up bias. So people who have certain characteristics might be less inclined to come for follow-up. So how do we deal with bias? So my lecturer used to say, bias results from bad study design and it's your fault. But I like to interpret that as we can do things to avoid bias in our studies. So it's about really thinking very, very hard about who's in your population group, who might you be missing, what are the characteristics of the people in the population group you're sampling from, and how can you ensure that you have representation in both cases and controls of similar people. Once a study's being conducted, you can't really do much about bias except acknowledge it in your discussion of the results. And you should do this. It's only fair to the readers of your papers that you acknowledge that there is bias in what you've written about. So we have an interesting type of bias that we can't avoid. I work with routine health data from our Department of Health. And we have, because it's quite difficult to get access to care, it's kind of time consuming, you sit in queues, you go to clinics, people only go for healthcare when they are unwell. So we have a large representation of people who have health conditions. And then we have a large representation of young women who are well and they come in for health, for maternal health and for contraception. So we have a very nice representation of healthy women, young women, and healthy women of childbearing age. And we have virtually no healthy men in our data sets because they don't go for healthcare because it's not required. And there's nothing we can do about that bias. When we write about the data, we just have to really clarify over and over again that we're very aware that this is a missing population in our data set. There's nothing we can do about that other than be very upfront about it. Yeah. Oh, sorry, jumped. Yeah, so you should really try and think about bias before you start the study. And then what is confounding? Well, we've had great discussions about this already, but sometimes there's an unmeasured or independent exposure which may affect the outcome and also expect the exposure of interest, but as an independent exposure. So the example, the classic example, similar to the classic example we saw yesterday, people who drink coffee are more likely to have cancer. In fact, people who drink coffee are more likely to smoke, and people who smoke are more likely to have lung cancer. So smoking becomes a confounder in this relationship. So how do we deal with confounders? They're not an error, they're real and their effects are real. But so there's statistical approaches to factor in confounders, which is exactly what we're talking about here in machine learning and in multivariate analyses. So when you design a study, you try and include data collection for as many possible confounders as you can. And you have to try and work out what those are by reading other studies, your biological knowledge or your clinical knowledge, looking at other publications out there. So you're really drawing on your domain knowledge and contextual knowledge to be able to ensure that you measure potential confounders in your study. So I think that's probably where we stop. These are just examples, but we don't need to go through those. They're there if you want to look at them. Yeah. So I think that's me. I hope it's been useful or a good summary. And we've got a bit of time if anyone wants to ask questions.
Hi. In the case control study, you mentioned that you could have it up to 4, or I mean, there are more than one controls that you can use.
Sorry, in the case control study?
You could have up to 4 controls for your case.
Per case, yes.
So why would you need more than one control for a case, and how do you decide that?
Yeah, so it's an interesting question, and it comes down to the ability to say with confidence that the effect you're seeing is real. So it improves the statistical significance to increase your control numbers. But at some point, it becomes impractical to have more controls. And honestly, I don't see many studies where people use more than 1-to-1 ratio. In general, people go for 1 case to 1 control ratios. So it's not necessary to have more. It's generally acceptable to have a 1-to-1 ratio. But technically, we are advised that 4-to-1 is actually the optimal ratio. You'll see in many studies, particularly in the genomic studies we do, often the biggest difficulty is finding controls. So I think it's really a pragmatic choice to go with 1-to-1. But when you have very large cohort studies, you can build these nested case controls. So that means that you artificially, from your population cohort, you can select a group who would be your cases and a group who would be your controls. And you can run a case control study on a subset from your cohort, a nested case control study. So in that case, you can increase the number of controls because you already have the data. Yeah. But I think, and I appeal to anyone else who's doing this kind of work if you'd also like to comment on this case control ratio. Thanks.
Thanks, Nicki, and it's a good question. I probably skimmed through it yesterday quickly, the data presented on post-GDM and cardiovascular disease. So we did manage to get 4 controls for cases. Really, the principle behind it is try and minimize the bias, especially when you are using a routinely collected data set or a retrospective data set. There's going to be a lot of errors, incompleteness of the data, unmeasured confounders, et cetera, So, and you also have a problem, say, for example, in diabetes, for example, age and BMI are the 2 main risk factors. So you could try and match them, but sometimes it's not possible to find the exact matching. So it's really trying to minimize the bias from 1-to-1. You're always going to have less cases unless there are specific examples where sometimes difficult to have number of controls. So that's really the principle behind in picking more than 1 controls per case. Is trying to minimize your unmeasured bias, really. Do you want to add anything?
Yeah. Thank you.
Thank you, ma'am. It was a really wonderful overview on this. I wanted to know your thoughts on standardization, because cohorts could be only on a particular ethnicity. And if there are studies that are to compare between different ethnicities, the variables that they've taken or the parameters that they've chosen would differ. So how would you propose that we tackle that as an issue? Because bias would exceed, or it could exponentially be different. I mean, it could affect the data, right? So what are your
So if I'm understanding correctly, you're asking me about how we standardize the collection of data. So I've got a whole lecture on that this afternoon. So hopefully we can pick up this conversation then. And I think, yeah, it's a really great point. So we'll talk about it later today. Thank you.
A really wonderful talk. I wanted to follow, I have a question following the discussion that happened about bias. How do you quantify bias? Because I'm not a clinician, but I've come across studies where there's a notion of risk of bias, where they compare studies and report it's a low bias study and a high bias or moderately biased study. Do you know any quantification that could?
Yeah, it's a good question. I don't, but I'm thinking about systematic reviews. So I'm again looking to the audience. And I think in the systematic reviews world, there are ways of assessing the different studies. So for those who haven't ever done one, I don't recommend it, but a systematic review is where you have a standardized way to collect all the studies. So it has to be repeatable and it has to be very verified, and the approach has to be very standard. You collect all the studies about a certain topic and you bring together all the results and you assess whether the result, how the results compare to each other. So Cochrane reviews, if you're interested in systematic reviews, they like the gold standard of systematic reviews. And my understanding is that when you do a systematic review, there's an assessment of the different studies that you do. So I would guess that in that system, there are ways to decide whether the studies were biased or not. But I think we've got some additions here. It's a great question, and I don't have a
so essentially, following on from what you've said, it's a green, amber, red system. It's not a numerical, at least to the extent that I know of this for systematic reviews. There's usually standardized ways in which the quality of a study is assessed. So there's, say you're doing a diagnostic study or you're doing a systematic review of trials. There is a protocol by which the quality of included studies is assessed, and there's usually a guideline on that. Or you can modify that guideline if your types of studies don't exactly conform, but that has to be done at protocol stage. And then you do green, red, and amber. So all you have is an output of included studies with green, red, amber on it, but it's not a numerical estimate.
So for those who are interested, Cochrane reviews, it's C-O-C-H-R-A-N-E, Cochrane reviews. And they've got a lot of tools for reviewing, for systematic reviews that may be useful. I'll also have a look, and if I find a good URL or something, I'll share it later.
There are tools, standard tools for type of studies. So for example, for observational studies, there are standard tools. For RCTs, you have standard tools. And as Nicki said, you look at Cochrane Review, or MRC, Medical Research Council UK, has a page which will tell you, depending on the study type that you are reviewing, you will be able to look at where the score, how do you score, etc. You can develop a numerical score, but then usually in papers they report it as red, amber, and green. So observational studies will be different, case control studies and cohort studies, as well as RCTs. So it's useful to look through the checklist and say how you are. Quite a lot of it is common sense, but sometimes it's useful to look through those checklists.
Sorry?
Equator.
Oh, okay.
There are many.
Different.
You guys use Google, but probably ChatGPT will give you a whole list, including references.
And in fact, if you submit an epidemiological paper to many of the journals, they ask you what your study type is. And then there are certain, I mean, I'm trying to think, one's like called strobe and another one's called something else.
Yeah.
So you actually can't submit your paper until you've filled out the journal's checklist. And those checklists relate to these standards, like quality standards that have been developed for the different study types. So if you want to do any kind of public publishing around your data types, you need to know what your study design was, and you need to be able to fill in those forms and show that your study design was up to scratch and that it's high quality now.
It is also ultimately increase the transparency of reporting.
Yeah. Okay, I think that was my flashing red light at the front here.
Thank you very much, Nicki.
Thank you. Yeah.